So my name is Joseph. I'm one of the cardiology registrars, and today we're gonna, for the next 30 minutes, we are basically gonna use a case-by-case review to try and explore the role of ECGs in the context of collapse, patients who attend the hospital and they've had a collapse. And based on that, we'll be able to have a look at the different management strategies in the context of syncope. Try to make it a bit interactive if technology allows us. If it doesn't, we'll change strategy as such. So the first case we're looking at is an 82-year-old male who has attended hospital. And the reason they've attended hospital is because they've collapsed, 2 episodes of collapse in the preceding 2 days. They're otherwise normally fit and well.
Hi, Joseph, are we meant to be able to see your screen?
Sorry?
Are we meant to be able to see your screen at the moment?
Yeah, I thought I'm sharing the screen.
Oh, no, I can't see it.
I don't think you can. I don't think you're sharing your screen, Joseph. If you're sharing, then you might not have picked up the right presentation. So try that again.
Okay, sorry. I'm supposed to be sharing the screen.
If you share and then select the presentation after you've opened it beforehand, all right, and then you can go to.
Yeah,
that's right.
Is it showing now?
Yes, thank you.
Oh, sorry, I'm just right. So
yes,
like I mentioned, Joseph Kazue, that's my name's one of the cardiology registrars, and I'd already mentioned to you that we'll be looking at cardiac syncope and exploring the role of ECGs in the context of collapse. And based on those ECGs, we'll look at the different management strategies in the context of syncope, and we'll be going to be doing it case by case. So the first case one, hopefully we are seeing it, the summary. We have an 82-year-old male who's presented to ED with 2 episodes of syncope. From the preceding 2 days, he's normally fit and well. You've gone to review him. The past medical history they've given us is of, has osteoarthritis and hypertension. He's on medications bisoprolol, 5 milligrams, 5 milligrams in the morning, and has a heart rate of 35 beats per minute. The BP is 135/70. You review him, and you find the above ECG. We're gonna take off time to study that. So the question we're gonna be having, the ECG that we are seeing, what does that show? And those are the options. I'll spend some time going back to the ECG. Hoping we've looked at that ECG, we will try to use a bit of Kahoot to see if we can manage. So I'll stop sharing this screen and then see if we can get onto the Kahoot, if it works well.
Yeah, it is. Great. Come on, get them fast.
Okay. Okay. So we're gonna Kahoot cardiac sync. Right. Hello.
Yes, we're there. The 90 people listening to you.
Yeah, 90 people. The technology is a bit slow on this side. So it appears like when I go to Kahoot, I lose you cannot hear me when we go to Kahoot. So stop share there. Right. So when we go to, are you able to see the presentation?
Yeah.
Yes.
Brilliant. So it appears like when we go to the Kahoot, I lose the audio, but the instructions would be, very clear. It will give you time. We have a full minute for each case, and we'll look at the numbers. So we are going back. The main issue has been the ECG that we are having. And the question is, what the ECG is about. I don't know if you can see the cursor very well on that side of the screen. Dr. Thacker?
Yes, if you open the chat box by the side, I'm moderating the chat as usual, so I'm just trying to put up the question based on the ECG. Okay, so
yeah.
I'm just trying to make up for the Kahoot thing. Okay, right?
Thank you very much.
And people can type in the chat box, and you can see that as well.
Okay, brilliant. So looking at, thank you very much, Dr. Thacker. So from the ECG, we can see that, the heart rate is 35. That is patient is quite bradycardic. That is likely not to be sufficient to give us a very good cardiac output to meet the demands of the body. So if we look at the ECG, clearly we can see that we can see a P wave there followed by a QRS complex, T wave, a P wave there, no QRS complex, but we can see another P wave, QRS complex, and this appears to be repeating itself. It appears like we're having 2 P waves for each QRS complex, 2 P waves for each QRS complex, and that will be consistent with a second degree heart block. Then the question is whether it is a MOBIS 1 or MOBIS 2. We've looked at we know that, first degree AV block is about the PR interval, which is prolonged. The second degree MOBIS 2, we have prolongation. It keeps on prolonging until it drops. And then in MOBIS 2, you have constant PR, but you have two P waves. If we have 2 P waves there, and then we have a QRS complex, and this pattern seems to be repeating, as we can see here and there. So it doesn't fit in clearly with a MOBIS 2. And then there is a marked relationship with the QRS between the P waves and the QRS complex. So the answer in this case is the MOBIS type 2. The patient was on a beta blocker, if we remember that. So in our management, we'll be looking at one, suspending the beta blocker, putting the patient on a monitor, looking at the blood pressure. It was 135, so they're still holding a good blood pressure. It's important to remember that usually patients of having heart blocks, because of the bradycardia, they have enough time to fill the ventricles, and quite often the blood pressure is preserved. The QRS complex was narrow, which is relatively a good prognosis. The beta blocker could be contributing to the AV block, so it's good to stop it, see what happens, and if it doesn't improve, we'll be looking at probably putting in a pacemaker based on that ECG. Just a few words about the different kinds of AV blocks. As you probably remember, first degree heart block rarely leads to any symptoms. Second degree heart block, the wink back, unlikely to lead to also symptoms in patients, but the last one, the second degree and third degree, patients are quite symptomatic. They can collapse, they can come in with dizziness, and sometimes actually they can go in asystole and die. So ECG is very important there, and it sort of directs us in the direction of the right management strategy. If we move on to the second case, that is case 2, we have a 45-year-old male who is presented with episodes of blackout. The past medical history, he really has nothing significant in terms of past medical history. He's been fit and well. One of the teams in A&E has had a bit, is good at echoes and has done an echo for the patient. That is TTE, transthoracic echo. It looks normal. It's important for us to remember that there is also TOE, transesophageal echo. So this is transthoracic echo, looks normal. You check his observations are looking stable. You do the blood tests are looking stable. And you move on to see the ECG, and we find that ECG. Now, because of technical difficulties, I'm not going to go back to the Kahoot. I'll appreciate Dr. Thacker if you look at the options and to save time, because it's hanging from my side. So appreciate that ECG. I'll come back to it in a moment. So you're the doctor on call, and you're asked to, for what the management strategy is going to be. So the options we're looking at, should we put in a Holter monitor? We put in a permanent pacemaker, an ICD, or reassure the patient and discharge them. So I'll go back to the ECG for us to have a look at it. I will not go back to the Kahoot. Dr. Thacker have can put in the options via the chat function. We'll give ourselves about 30 seconds.
Are you moving your slides forward, Joseph?
Yeah. So we've had enough time to look at that. Look at the answers.
I don't think your case has come up yet. It's still on case 1.
Oh, it's still on case 1. That's very strange.
You might need to try sharing it again.
Okay.
Are you using the hospital Wi-Fi?
I'm using the hospital Wi-Fi. It's a bit, okay, so screen share again.
Apologies, everyone.
There again, are we able to see it?
Just select your slide, case 2, and then we should be able to see it. Thanks.
Case 2.
I think one good thing might work better is to just keep in this sort of a mode, and then you can just move forward, and then we can just carry on with your talk. All right?
Okay. So are we seeing case 2 now?
Yes, yes.
Okay. Are we seeing the ECG now?
No. Yes, it's there now.
Sorry?
Your ECG was on.
The ECG, oh, it's just slow.
Yeah, so why don't you open your PowerPoint and don't go to the presentation mode? Just keep them in the, in that slide view. And we should be able to, and then when you're happy, you can just move forward. All right?
Okay, there. Share. Are you able to see the ECG now?
Yes, yes. Let's get on with the.
Okay.
case.
Okay, fair enough. Right. So looking at that ECG, so the ECG for case 2, if we look clearly at the right precordial leads, they are showing, so we look at the rate looks quite okay. So we are moving at about 1, 2, 3, 4 divided by 300, so about 70s, 70 to 80s. If we look at the right precordial leads in V1, V2, and V3, we can see that we see a bit of ST elevation in those precordial, right precordial leads. And that ECG is consistent with Brugada Syndrome, one of the substrates for ventricular arrhythmias. Specifically, it's Brugada type A. So for this patient, we can see that it is classical Brugada. We have ST elevation of more than 2 millimeters in the right precordial leads. So this patient this ECG is quite diagnostic of Brugada syndrome. We know that this is a substrate for ventricular arrhythmia, and this patient is likely to experience more along the line, down the line. And if we're looking at the options of management, so pacemaker is probably not, we look at the Holter monitor, we're probably not going to pick much from the Holter monitor because we already have a diagnostic ECG. We're looking at option B, pacemaker, and like the other patient who collapsed with a heart block, Mobis type 2, this patient, the problem is different. Are we discharging the patient home? It's probably not the right thing because it's likely to have other collapses. So the right option should be option C. This patient will need an implantable cardiac defibrillator to shock him, to give him therapeutic shocks in case he gets these other ventricular dysrhythmias. So these two cases so far demonstrate we have patients that are collapsing because of cardiogenic cardiac reasons, but the management is slightly different, and the ECG is quite important in guiding us in the direction of the management. So if we move to case 3, I hope it's showing on your screen. Dr. Thacker? No. 25-year-old female who's been brought into ED following a collapse, normally fit and well, past medical history, nothing really significant. The bloods have been done and they are looking all right. Observations are stable.
You want to bring forward straight to the slide of the ECG so that you could, the ECG is not visible.
Okay, so I've brought back the ECG. I'll give it a bit of time to update. Let me know when it's updated.
Yeah. So why don't I unmute myself, and in the interest of time, I'm now unmuted, and
right.
I'll let you show up your don't share screen. Just move on to your ECG, and then we can talk through the case.
So I've got my ECG on at the moment.
I don't know, it's not showing up on the screen. So you may again have to perhaps go unshare and then share back.
Okay. Okay, there we go. So I'll share that ECG again. So are we able to get the ECG?
That's right. So that's
okay.
there. Just talk through and then let people make their immediate impressions.
So I'll give it 30 seconds for people to have a look at the ECG. I apologize for the technology. We'll work, it's what it is. We'll work with what we have. I'll give people a few seconds to look through that ECG, have a few ideas.
So let people type in the chat box as to what are the key finding? I mean, what's the immediate thing which comes to their mind if you just have a quick look at this tracing? Let alone the history, you can tell the story a bit later on. Wonderful. So I think people are getting it quite right. There's a striking distance between the beginning of the QRS complex and end of the T wave, which is actually, if you see in lead 2, is almost reaching the end, the beginning of the P wave. So it's a very classic case of what is long or prolonged QTC as the only finding. So yeah, people have got it quite right. So are you hearing, Joseph?
Yeah, I'm good. Thank you very much. So I've shared the slide of doctor on duty. I don't know if you're able to.
I'm going to be asking them a question as to what are the most common causes.
Okay.
And they can type the answers if they've seen this on their wards and you know, even on a routine ECG in primary care. So you can talk through, or you could perhaps type whatever's more convenient. So if you had to really pick on a couple of most common causes, so medications, electrolytes, well, which electrolytes to be specific? Fantastic. So there's all sorts of causes and responses coming. Yeah, antipsychotics, macrolides, amiodarone, low calcium, that's right. What about magnesium? What about potassium? That's right. So fantastic. So, you know, so we've covered, are you seeing the chat box, Joseph?
The chat box, I'll get it.
Yeah, keep the chat box open and then you'll see such a wonderful spread of responses.
Yeah.
All right, you happy with that?
Yeah, antipsychotic drugs,
Yeah.
macrolides, amiodarone, low potassium. Yeah, QR Pro. Yeah.
But let me ask them a question, and along with you actually, who's the presenter. Apologies. So if you see this ECG coming with someone who comes to you, you know, you're clerking this patient, and he or she has presented with an episode of fainting. What would you suspect? So you can type your responses. Bloods are normal. Has anyone seen a long QT or clerked someone with a long QT in on their shifts, or you know, medical wards or elderly wards or acute medicine on calls? So there's a response called usually asymptomatic. Yes, it can be, certainly. But I must say that, and I'll type it for everyone, that there is a linear relationship between the length of the QT interval and the risk of serious ventricular arrhythmias. So the QTC interval between 450 to 500 milliseconds is generally labeled as mild. 500 to 600 is generally moderate. 600 and higher is severe, beyond which the risks are much higher and you really have to try and intervene as much as possible. We do get referrals from psychiatric units and, you know, other places where people are on long-term complex medications with potential to increase QTC are much higher, and a little bit of electrolyte imbalance, weight loss and stuff like that can just tip off the QTC from a baseline of 450, 500, which they're maintaining, and it kind of just goes up. And then it then generally needs some sort of an intervention in terms of medical optimization or something. And of course, it rightly says that possibly went into VT when they had syncope. Fantastic. That's what would generally I would expect, that they must have had an episode of arrhythmia, and then this is a can of worms. The moment you see that ECG, it's like opening a can of worms, which then you need to start investigating, because what's evident currently in terms of QTC interval prolongation seen in clinical practice is more like a tip of the iceberg. I'll let you talk, Joseph. Thanks.
Yeah, thank you very much, Dr. Taka, for those words of wisdom. So I think generally the audience have a good understanding of QTC and its management. The management is going to be really in line with, the risk factors. If we check and we think the patient is very hypocalcemic, is very hypokalemic, then we're probably going to have to replace those electrolytes and, keep an eye on the QTC. If we think the problem is being the medications that we are using, then the management is going to be different. We need to cut down on these medications. And if it's congenital, we probably want to think of trying to use beta blockers. There is some good evidence that they can be useful in preventing collapse in patients with prolonged QTC. And if beta blockers are not working, the second line can put in, they can be shocked from these ventricular arrhythmias. So the management is going, you'll have a look at the ECG, we'll know that, it's the QT problem, it's prolonged, then it will help us look at other issues. So I think a few causes I've not looked at. Temperature is another one that can, if patients are hypothermic, they can also get prolonged QTC. We'll move on to the next ECG. I apologize for the...
Yeah, so do the same thing for timing purposes. Just show up the ECG and talk about the case. Thanks.
Okay, brilliant. Thank you very much. So we are left with only 2 ECGs. I'm keeping an eye on the time. So we have the next patient, and that is the ECG at hand. That is the ECG at hand. Take off some time to have a look at that ECG and how best would we manage this patient. I'm hoping, Dr. Taka, you can see the ECG your site well.
Everyone can see that. If you give a clinical history, clinical profile, they'll be able to start to respond. Thanks.
So 75-year-old gentleman, normally fit and well, has had some ischemic heart disease 5 years ago, and has come in with 4 collapses over the past month. We go to check him out, and his observations are quite stable, but the ECG is as shown. So his blood pressure is maintaining okay. We've done his bloods, they're looking all right. And his Muse score is 0. We get that ECG right in front of us. And then the next question is, what do we think, and how, what do we think the ECG is showing, and what is the best way forward? So I can see some answers coming in. I'll give like maybe 20 more seconds, and then we'll talk about the ECG.
Keep an eye on the chat box, and you'll have people responding. Thanks.
Okay, good. So chat box, I'm seeing answers coming in. Okay. Yeah, right bundle. First degree AV block with right bundle, the ischemic changes, right bundle, Mobis type 2. Yeah, I think we have complete heart block. Yeah, so we have, so I think, yeah, we'll just put it all together. So looking at that ECG, so if you can see the cursor, so I think we've got it all there. We'll just put it together. So yes, if we look at that, if we can see the cursor, yes, people who have said right bundle branch block. So it is there. If we look, if we had our QRS duration, it will definitely be more than 120. If we look at our PR interval, as you can see from the cursor, it's quite prolonged. It's more than 1.5 squares. So we surely have got there at least a first degree heart block. And then for people, if we see it's negative in lead 2 and in lead 3, but positive in 1, so we definitely have left axis deviation. So I've seen all these answers, and then we can all put them together. So we know that, the left axis deviation that we're seeing in this ECG is consistent with the left anterior fascicular block. We know that the right bundle is also blocked, and we know that there is AV node. So there is definitely a conduction disease in this patient. So this ECG is one that is consistent with what we've traditionally referred to as a trifascicular block. But as you, so, well, this would be an ECG commonly we'll call a trifascicular block. But as maybe Dr. Thacker might slightly disagree, more research is showing that actually trifascicular block is a misnomer because the AV block is not considered another fascicle. But this is significant conduction disease, and this patient will need a pacemaker. Traditionally, we've called this a trifascicular block.
That's correct. Just to give a slightly extended perspective, that it's just a precursor to complete heart block. However, currently the guidance is a split, and the general guidance about intervention is that if someone with this sort of a ECG on routine screening is not symptomatic with the pacemaker, unless for safety reasons, unless they live on their own, unless they're elderly, where you expect them to degenerate at some point, you don't generally intervene, maybe stop the beta blocker, etc., and monitor. But you expect that they will need a permanent pacemaker at some point in near or distant future. So it's just a precursor to complete heart block and shows degeneration of the conduction system significantly. The only thing here, to happen, perhaps waiting to happen, is dissociation of the upper chambers from the lower ones. With a complete AV dissociation, complete heart block has been known. So for practical purposes, this is a jargon, a name. You have to give it a diagnosis, electrocardiographic diagnosis, and that is trifascicular block, which means everything's blocked. However, there is no dissociation between the upper and the lower chambers as of now. Thanks.
Thank you. Thank you much. Thank you very much, Dr. Thacker. So this patient, if they are symptomatic, we probably do nothing. But if they are symptomatic collapsing, the next best thing is to put a pacemaker into them. We'll move to the last ECG. As I can see, time is, we are chasing time. So this is the last ECG. So the case is of a 60-year-old male who's been brought to hospital following collapse. He has a past medical history of non-small cell lung cancer. You examine him and you find his heart rate is about 105 beats per minute. His blood pressure is about 90/70. You move to see his ECG and we find the above ECG. We'll look at the ECG. Let's take some time to look at the ECG. We'll look at the comments for probably 30 seconds, and then we'll discuss the ECG. So I'm looking at the comment section. So I can see pericardial effusion. Start from left, go right, tracing. Yeah, okay. So pericardial effusion, what's the most evident? Yeah. It is a swinging ECG, so it's a big pericardial effusion. I'll give it 10 more seconds. I don't think we're getting any more in the interest. Okay, yeah, there we have. Yeah, pulsus alternans. What's the most electrical alternans? Very good, great. Well, cardiac tamponade. Well, I think the class is either too clever or the lecture has been very on point. I would have to agree with all of you. I think the ECG, the ECG, I think, the answers are completely bang on. So it's a classic. I don't know if the giveaway was this lung cancer, but I'm hoping that, people could tell also from the ECG, yes, electrical alternans. And we can see big complexes, small complexes, and somebody has even given us the pathophysiology. I think that is Lizzie. It is a swinging ECG, so a big pericardial effusion. The question was, what would be the next thing for you to do? We would probably, do an echo ask one of your seniors to do an echo. They will confirm the diagnosis. We know the patient is actually, tachycardic. The blood pressure is dropping. Somebody has said, I think it's Chrissy Patel, cardiac tamponade. Yes. So I would have to completely agree with you. And then the next best thing is not a pacemaker, is not an ICD, but we'll be looking at a pericardial drain for this patient. So well done, guys. I apologize for the problems with the technology, but thank you, Dr. Thacker, that we managed to go through the ECGs. And I hope I can put one slide for the conclusions, and I hope it works.
Just to finish off quickly, I think I've just made a little comment that it is electrical alternance. However, the voltage doesn't look to be too small, as you would expect in the pericardial large effusion type thing. So that's the only thing you need to keep in mind. However, quite bang on and quite spot on in terms of observation. So well done, and thank you, everyone.
So thank you very much. I'm hoping I can see that one for summary.
Yes.
Dr. Thacker? Very good. So in summary, for the last few minutes, for the last 30 so minutes, despite the problems with technology and our planned Kahoot, I hope we've been able to sort of have a chat and realize that, people, there are several causes why people can collapse, and they are cardiac in origin. And I hope we all appreciate the role of ECG in helping to give us an idea on what the likely cause of the collapse is, and subsequently informing the management strategy. Thank you very much. Over to you, Dr. Thacker.
Thanks, Joseph. I'll let you stop sharing, and then I'll ask Sabyasachi to take over straight away. Sabyasachi, are you logged in?
Yes, sir.
Hi.
Can you hear me?
Well, let me just yeah. So you should have the sharing things, and just get on with it. Sabyasachi is our one of our SHOs in cardiology, and has prepared a wonderful talk on heart failure, current perspectives, and we look forward to hearing from him. Thank you. Over to you.
So am I audible? Hello, everyone. Hello.
Yes, you are. Carry on.
Oh,
thanks.
Oh, thank you. Thank you very much.
It's good to see that we still have the full house. So, we're literally, I mean, not far away from, not too far away from the time, but apologies for slight delay in the session.
No.
But I'll let you carry on, Sabyasachi. Thanks.
Oh, thank you very much, Dr. Thakur. Hello, everyone, and welcome to this session. I'm sure everyone is quite tired now, but I'll try to make it as short possible, though it's a big topic, actually. So I'm talking about cardiomyopathy and heart failure. I'm Sabyasachi Mitra. You can call me Mitra for your purpose. So heart failure and cardiomyopathy both are big topics. So I'm just trying to sketch out what cardiomyopathy is and how heart failure is related to cardiomyopathy in the next few slides. So I hope that helps. So I'll start with what is cardiomyopathy. So it's quite easy to understand through the name. It's something to do with the disease of the heart muscles. So cardiomyopathy. So what it is the disease of the heart muscles. That's quite obvious. So we can say it's defined as the diseases of the myocardium associated with cardiac dysfunction affecting the mechanical or electrical function of the heart. So disease of the heart muscles and making them dysfunction. So dysfunctional. So what it is easy, really. What it is not is something that's we need to understand at our level. So what it is not is important because when we think of cardiomyopathy, we occasionally come over ischemic cardiomyopathy and other things like that. So these are actually not primary cardiomyopathies, or not. These might be a misnomer. So anything which is not, the muscles are not the culprit for the main disease called possess, is not cardiomyopathy. The muscles have to be the primary cause of the disease to be called cardiomyopathy. So if it is secondary to other factors like hypertension, valvular heart disease, or coronary artery disease, which leads to ischemic cardiomyopathy, it's actually the other things which are the culprit and not the primary disease of the muscles. So it's not a cardiomyopathy if it's from those causes. So that's something of a concept that has to be cleared from the beginning, so that we do not think that hypertension or valvular heart disease like aortic stenosis, those which cause increased workload on the heart muscles or increased workload on the left ventricle, or pulmonary hypertension, which might cause increased workload on the right ventricle, these cause disease to the heart muscles as well, but they are not the primary culprits. The primary culprit is somewhere else. So we need to treat them to treat that disease. And while in cardiomyopathy, it's more of a muscle disease which needs to be treated. So I'll go into it. So cardiomyopathy classification is a bit of a problem. There are a lot of classifications involved in it. So I've tried to summarize here. So cardiomyopathy can be classified as mainly the main common reasons of cardiomyopathy are, common types of cardiomyopathy are hypertrophic cardiomyopathy, dilated cardiomyopathy, and arithmogenic cardiomyopathy, usually right ventricular, but can also involve the left ventricular, and restrictive cardiomyopathy and LV non-compaction. So you can see the prevalences here, and you can see the muscles here. So the picture shows the normal LV and the normal RV and how the muscles usually look. So in hypertrophic cardiomyopathy, the muscles usually become hypertrophied or enlarged. In dilated cardiomyopathy, the muscles are thinned out as the whole cavity is dilated. So it's a cavity which dilates and the muscles get thinned out. And arithmogenic cardiomyopathy, you can see that there are white fibrous tissue that which gets settled there. In restrictive cardiomyopathy, there is increase in the volume of the muscles, but due to deposition or due to other reasons, it's not actually muscles which have become hypertrophic, but there are depositions of other things. And LV non-compaction is a disease where there is spongy muscles. Actually, the muscles are not compatible for enough pumping function or contractility. So that's a real rare thing which we might not come across really. So moreover, it can be classified as genetic and non-genetic or acquired. So we'll come across that in each of the steps next. So what is hypertrophic cardiomyopathy? It's actually the hypertrophy of the muscles, which are not secondary to abnormal loading conditions like hypertension and aortic stenosis. So it's not the muscles which become hypertrophied because of increased workload from AS or hypertension, but it's the muscles primarily getting thicker and getting hypertrophied. So with the hypertrophy, what happens is it can be autosomal dominant, it can be autosomal recessive. Prevalence is much more than the other types. It's usually 1 in 500. So the common types are the asymmetric type or asymmetric septal type, which is known as the classic hypertrophic cardiomyopathy, which involves the asymmetric hypertrophy of the septum. Only the septum is hypertrophied, the other walls are fine, which causes it to collapse before the whole of the blood is coming out of the aorta. So it can cause the obstructive hypertrophy, or it might be non-obstructive if it doesn't collapse the aortic valve. And there are other types like concentric and reverse septal and neutral and apical. So apical is a more common type than the other ones. So asymmetric septal is the most common type. The second most common type is apical, which is found in about 25%, 10 to 25% people. So apical hypercardiomyopathy is really, the apex is hypertrophied, and it's more involved in having more sudden cardiac death and ventricular tachycardias. So what happens in hypertrophic cardiomyopathy is Okay, so we'll go into the why, the reasons of cardiomyopathy, hypertrophic cardiomyopathy. So there are genetic causes. We'll not go into details of this. This is not required, but just for the fullness, I have kept it. So there are genetic causes. There are storage diseases, which are also genetic disease, and there are primary muscle disease from mitochondrial disorders, which involve multiple organs, which might also involve the heart muscles, like Friedreich's ataxias and mitochondrial disease like MELAS and MAR, and other malformation syndromes, which are all genetic. So it's all genetic causes really, and storage diseases, which cause this hypertrophy. So you can see another picture of an asymmetrical septal hypertrophy here. So what it does is it reduces the cavity in which the blood fills, and it also can cause an obstruction to the aortic valve for the full pumping out of the blood from the aorta during systole. So in diastole, there is reduced filling, and in systole, there is reduced output due to obstruction in 1/3 of cases. So not all cases are obstructive, but in 1/3 cases, there might be obstruction. So I'll go into the complications with HCM. So often it's, as I said, it is involved with diastolic dysfunction. So we'll go into diastolic dysfunction and heart failure with preserved ejection fraction in the next few slides. But it is here we begin with this. So it is the filling defect. The heart is unable to fill completely in the diastole as much it should have filled. So that's the diastolic dysfunction. The diastole is not able to fill up the whole blood, which it should have filled. So that's the heart failure with preserved ejection fraction and diastolic dysfunction that's causing due to increased muscles and decreased amount of cavity left. So the main killer in hypertrophic cardiomyopathy is not the diastolic dysfunction or the obstructive cardiomyopathy being an obstruction to the outflow. So the obstruction to the outflow or the inflow is not really the killer in hypertrophic cardiomyopathy. The killer in hypertrophic cardiomyopathy, or the reason why they come with sudden cardiac death, is because of ventricular tachycardia. So increased muscle mass is always a source of, or I should say, a disease in the muscle mass is always a source of ventricular tachycardias, ventricular reentrant tachycardias, and things like that. They're the focus of increased ventricular ectopics, and sometimes those ectopics can turn into tachycardias. So increased muscle mass or diseased muscle mass in the ventricles is always a source of ventricular tachycardia, and those are the killers. So they might come with unexplained syncope, and we might have to think about ventricular tachycardia. So usually with athletes with hypertrophic cardiomyopathy, usually they end up with having a sudden syncope and cardiac arrest because due to increased workload, there is increased chances of ventricular tachycardia for them. And abnormal blood pressure response to exercise, that's another thing which is seen, which we can diagnose from. So exercise-induced hypotension. Normally in exercise, we should have the blood pressure rising up because the workload increases. But in exercise, what happens? The heart rate increases, the diastole shortens, and there is even lesser filling of the heart, and which causes lesser amount of blood to pump out. So blood pressure response goes down. So blood pressure goes down during exercise. So another important point in the history would be a family history of sudden cardiac death, because as I pointed out, hypertrophic cardiomyopathy is usually genetic. So it can be that they had someone in their family who had a sudden cardiac death as well, or hypertrophic cardiomyopathy as well. So the least important thing is left ventricular outflow obstruction, really. So we might have that in 1/3 of cases, but that's not really a concerning thing. The other factors, that's why I have said before, the left ventricular outflow obstruction. And due to the diastolic dysfunction, due to the increased preload, increased workload on the left ventricle, increased preload in the left atrium, the atria can dilate and cause atrial arrhythmias, atrial fibrillations, which can lead to thromboembolism. So that's another complication. And obviously, with more and more workload on the heart, always remember all the hypertrophic cardiomyopathies, all the cardiomyopathies ultimately might lead to end-stage systolic dysfunction. That is actually the burnt out stage of hypertrophic cardiomyopathy, when the muscles cannot keep up to the workload anymore and ultimately start dilating and start having end-stage systolic dysfunction as well. So that's burnt out hypertrophic cardiomyopathy. So the management involves really, the management is about decreasing the chances of sudden cardiac death, decreasing the chances of ventricular tachycardias, ventricular ectopics, and helping with increased diastolic filling. So beta blockers, calcium channel blockers, which decrease the heart rate, would help by increasing the diastolic filling, because it increases the heart rate, decreases the heart rate, increases the diastolic time. And it also decreases the contractility. Beta blockers help in decreasing contractility, so the muscles would not collapse and cause an obstruction. So beta blockers are indicated in obstructive disease as well. Calcium channel blockers are actually not indicated, contraindicated in obstructive disease. So you have to find out whether it's an obstructive disease before you give an calcium channel blocker. And diuretics, as usual, they are the main line of heart failure, which might be associated with hypertrophic cardiomyopathy. So they give benefits, symptomatic benefits for the dysfunction. And for invasive treatment, for really for focused treatment, really to correct the hypertrophic cardiomyopathy, we can go through surgical myomectomy or alcohol septal ablation. So there's a few patients who would improve from surgical myomectomy, few would improve from alcohol septal ablation. Grossly, it's the younger patients we do surgery on, it's the older patients we do septal ablation on. It's less invasive alcohol septal ablation. So both the ways, we decrease the septum or decrease the muscle mass in that way. And ICD implantation is really another way of stopping the VT or sudden cardiac death. VT is ventricular tachycardia, SCD is sudden cardiac death. So I'll move on to dilated cardiomyopathy. Sorry, Dr. Thakur, is this too fast? Should I slow down? I'm sorry to ask. I'm asking others as well.
I think
Is it okay?
I think you're fine, but you may want to people may want to put in the chat box if they feel it's going too quick. Or maybe
Yeah.
There's nothing in the chat box so far.
Okay.
Good pace.
I can't see the chat box really. Sorry, for some reason.
Yeah, it's a good pace, but we don't want you to kind of rush through too much. So you're not rushing.
Yeah, and I don't want to overburden it because it's a huge chapter. I don't want to overburden too much.
You're not over. You're not going. It's just a reasonable pace, I guess.
Okay. Okay.
So,
Yeah.
and we have time, so we have 20 minutes to finish.
Okay.
However,
Okay.
I think 5 minutes for wrap up, 5-10 minutes. So
Okay. Yeah.
thank you.
Okay. Thank you. Thank you, Dr. So I'll continue. So dilated cardiomyopathy, that's where the cavity dilates and the muscles thin out. So it's just the opposite of hypertrophic cardiomyopathy, where the cavity becomes small. So dilated cardiomyopathy, again, you have to understand, I will repeat that ischemic cardiomyopathy is a disease where the heart muscles thin out because of dying out. But ischemic cardiomyopathy is not dilated cardiomyopathy. Ischemic cardiomyopathy is not a cardiomyopathy at all. It's a disease of the coronary artery disease. So it's an ischemia which is causing it. So you have to show the ischemia and not the muscles. So dilated cardiomyopathy is, again, the disease of the muscles. It has several causes. I'll just point out the few which are very important. So it can be genetic, as usual. It can be infective. So infections, viral infections and viral myocarditis is a very common cause of dilated cardiomyopathy. So sorry, is someone saying something?
Someone's on unmute. So could you mute yourself? Thank you.
So infections and viral infections mainly, which are really harmless. There might be an adenovirus or some virus which caused 7 days of viral fever, and he or she didn't even attend any GP or anyone, and suddenly he comes with a heart failure, and you're thinking, what happened? What went wrong? So it can be a reason. So viral infections is a very common cause of dilated cardiomyopathy. They suddenly come up with a cardiomyopathy because of the myocarditis, causing the muscles to fibrose and thin out. So inflammatory causes, just like the infections, inflammatory causes, the chronic inflammations like rheumatoid arthritis, SLE, they're all involved with involving the heart muscles. They can involve the heart muscles. Another very common cause is alcohol. So alcoholic cardiomyopathy is actually the same as dilated cardiomyopathy. So alcoholic cardiomyopathy, people with very chronic high alcohol intake may come up with thinned out muscle mass and dilated cardiomyopathy. Similar with cocaine and amphetamines and others on that list. Hemochromatosis and amyloidosis, I'll point out that they can be leading to dilated cardiomyopathy. They are more commonly known to lead to restrictive cardiomyopathy, as you can see later on. So hemochromatosis or iron overload and amyloidosis, two deposit storage disorders and deposit infiltrative disorders, they usually cause restrictive cardiomyopathy, but can cause dilated cardiomyopathy as well. Drugs, well, chemotherapy is a very known cause, usually anthracycline, a long-term anthracycline use can lead to cardiomyopathy, usually dilated cardiomyopathy. And there are other drugs as well. I will not go into deep of that. So endocrine, diabetes mellitus, acromegaly, thyroid dysfunction, and usually hyperthyroidism can lead to dilated cardiomyopathy. And peripartum cardiomyopathy, this is another cardiomyopathy which I'll come up in a later stage. It's usually due to the prolactin. Prolactin causes defect in the heart muscles due to some oxidant and all that. So I'll come into that later. So dilated cardiomyopathy can be synonymous with heart failure with reduced ejection fraction. So usually the heart failure that is found in dilated cardiomyopathy is always heart failure with reduced ejection fraction. So usually you will not have a preserved ejection fraction with thinned out heart muscles. So the muscles are not compatible enough to keep up with the 50% or above 50% ejection fraction that's required. So in echoes, you will see that the heart failure has reduced ejection fraction. So the same thing again, the prevalence is 1 in 250, the ventricular dilatation and systolic dysfunction almost always leads to heart failure with reduced ejection fraction. So the management options are as same as heart failure with reduced ejection fraction really. So what we do in heart failure with reduced ejection fraction, we start with ACE inhibitors. ACE inhibitors are known to reduce the remodeling of the heart muscles. They also reduce the afterload by vasodilating. So they reduce the blood pressure, they reduce the afterload against which the heart has to work. I'm sure you're known to the concept of preload and afterload. If you are treating a heart failure, we have to treat the preload. We have to reduce the preload and we have to reduce the afterload. Afterload is the blood pressure in the aorta against which the heart muscles have to work. And preload is the amount of blood which is coming into the blood during diastole. If it's huge, then obviously it's going to take a lot of the muscles to work out. And if the ejection fraction is low, there will be accumulation of more and more blood into the ventricles. So we have to reduce the blood coming into the heart, and we have to reduce the pressure against which the heart has to work. So that's the reduction of preload and afterload, respectively. So ACE inhibitors reduce the afterload by reducing blood pressure and also reduce the remodeling of the heart muscles and reduce and are beneficial in heart failure, have mortality benefit as well. So ACE inhibitors, if cannot be tolerated because of some reactions like cough and etc., then we go into ARBs. ARBs are the sartans, telmisartan, losartan, and all that. And after that, the newer drugs which have come in is valsartan and sacubitril combination, which is marketed as Entresto. So it has shown in studies that it is better than ACE inhibitors. or ARBs. So it's an ARB along with a sacubitril, which is, I believe, naturalizing peptide or something like that, which increases the amount of renal flow and increases the amount of urine as well. So it has a combined effect of ACE inhibitors and diuretics together and help the heart better. So it's just a step up from the ACE inhibitors, really. And so beta blockers, they reduce the blood pressure, they reduce the heart rate. Yes, beta blockers also reduce the contractility, which would have been beneficial in hypertrophic cardiomyopathy, where we want to reduce the amount of contractility. But in dilated cardiomyopathy, they also reduce the contractility. I agree that is a problem, but the benefits of reducing the heart rate and reducing the blood pressure outweighs the benefit, the risk, or the problem with the reduction in the contractility. So digoxin is another which increases contractility, which actually acts by increasing contractility and reducing heart rate. So it acts both ways. Diuretics, as usual, give symptomatic relief. They are better. The spironolactone or eplerenone, which are the mineralocorticoid antagonists, they have a benefit on the heart failure, mortality benefit on the heart failure. But the furosemides and the thiazides, they don't have any mortality benefit, but they have symptomatic relief because we reduce the preload, we reduce the amount of blood going into the heart in the first place. Ivabradine, another one which reduces the heart rate and helps reduce the heart muscles workload. And blood thinning medications or anticoagulants, because of the increased workload, there will be a back pressure on the left atrium. The left atrium will dilate, and any dilated left atrium is a focus for atrial fibrillation. So atrial fibrillation can happen, can be associated with it, and then we will have to go into anticoagulants. Dilated cardiomyopathies might also be involved with portions of the left ventricle which are not moving very much, and they can lead to LV thrombus as well. So we might need to think about anticoagulants in that case as well. So moving on, dilated cardiomyopathies, we can also, or in case of heart failure, reduced ejection fraction, we might help with some therapies, which include biventricular pacemaker, or as it is known, cardiac resynchronization therapy, or CRT. So what this device does is it sends electrical signals to both the ventricles, the right and the left, and they resynchronize both of them to pump at the same time. So what it does, it increases the ejection fraction by a small bit, at least 5 to 10 or 15%, by increasing the synchronization between left and right ventricle. But to really help have this work, it has to be desynchronized in the first place. So usually it's a dilated cardiomyopathy or heart failure with reduced ejection fraction below 35% with a left bundle branch block, which would benefit. Nowadays, even right bundle branch block are thought to benefit from this. So if there is a bundle branch block, if there is a desynchronization, if the right ventricle and the left ventricle are pumping at different times than each other, then if we send electrical signals and make them pump at the same time, then it can improve. If it is already synchronized, then no point in doing that. If in those cases we can think of an ICD, so ICD would not really benefit the dilated cardiomyopathy or the heart failure. It would only prevent life-threatening arrhythmias like VTs, ventricular tachycardias, and sudden cardiac death. So the same thing again, any cardiomyopathy, any disease with the muscles get fibrosed, muscles get thickened, muscles get thinned, there is focus of ventricular tachycardias, and we can prevent them with implantable cardioverter defibrillators. They are just shock machines inside your heart, inside your chest, with electrodes into the heart. And left ventricular assist device, this is again a stopgap thing. It's not really a long-term thing yet. It's a device which is inserted in the epigastrium or in the left lower chest wall, and it actually helps the heart pump. So it's actually in touch with the left ventricle, and it pushes the left ventricle during systole. It has a ECG monitor. It monitors the systole and it pumps blood. Helps the left ventricle pump blood. And it is actually a stopgap before a heart transplant. So heart transplant is the final way of getting out of dilated cardiomyopathy, really, because once the muscles are thinned out, you will never really get those muscles back. So heart transplant is the final process. So now next we move on to restrictive cardiomyopathy. So restrictive cardiomyopathy is where the muscles are not thickened. The muscles are the same volume and same thickness as the normal, but they do not have the enough relaxation to fill up during diastole. So they do not relax enough. So the compliance, we call it the compliance, is low. The diastolic compliance has reduced, or the muscles don't relax enough to allow enough blood flow into the left ventricle from the left atrium during diastole. So the volume reduces, the diastolic volume reduces, the same thing as hypertrophic cardiomyopathy, but it's not because of the muscle thickening. It's because the cavity doesn't increase, doesn't expand enough, because the muscles don't expand, the muscles don't really relax enough. So it's the same diastolic dysfunction. So enough blood doesn't come in. So the left atrium dilates, the biatrial enlargement and dysfunctions can happen. And there is pooling of blood into the pulmonary veins, pulmonary arteries, and the pulmonary hypertension and pulmonary edema. So all that is a backward failure, really. So it also presents in a similar way to a constrictive pericarditis, which is not a muscle disease. So the pericardium actually becomes very stiff. So it's not the muscle which has become stiff, the pericardium which becomes stiff or filled with something. And so the muscles cannot relax, muscles cannot expand, and the volume is not enough in the diastoles. So again, the heart failure with preserved ejection fraction, similar thing. Diuretics can help with something, but it's really a prevention of VTs and atrial fibrillation management, again, which we really target on.
Got 2 minutes. Go 2 minutes to sum up, Sabyasachi.
Sorry.
You got 2 minutes to sum up.
Okay. Restrictive cardiomyopathy, also the disease of storage disease, infiltrative disease. The main two causes, amyloidosis and sarcoidosis, hereditary hemochromatosis, and other endomyocardial disease as well. So I'll go ahead now because ARVC is arithmogenic right ventricular cardiomyopathy, mainly because of arrhythmias, mainly VTs coming from that. Left ventricular non-compaction is a rare thing. I will not go into that. Inflammatory myocarditis, I have already talked about. Stress or Takotsubo myocarditis is the myocarditis from stress. It presents like an acute MI, but is not due to any artery disease or spasm. It's from the hyperadrenalism, which is from the stress. And peripartum, I have already said, all these leads to dilated cardiomyopathy. So we have gone through the presentation, really. The presentation is usually heart failure or syncope. So heart failure, dyspnea, chest discomfort, palpitations from VTs, and syncope. So those are the two things that can really come up as a presentation. So heart failure or VTs, those are the presentations. So the diagnosis we go through by ECG, blood test, chest X-ray. So cardiac imaging is the main thing that needs to be done. So echocardiography to distinguish the type of cardiomyopathy, hypertrophic, dilated, restrictive. And then we can do exercise stress test and cardiac CT if we are trying to find any coronary artery disease. And MRI is the gold standard, really, which tells us what the disease is, where the disease is involved, and how much we can do about that. And cardiac catheterization would also lead us to the ventriculography. The ventriculography is a study where we see how much flow is coming out of the ventricles by projecting some dye into the ventricles. So that's also a very useful study to find out how much is coming out, how much is getting obstructed or anything like that. And the genetic testing, endomyocardial biopsy, all that as well. So again, so what is cardiomyopathy? We went through all that. Remember, it's not from hypertension, valvular disease, or coronary artery disease. It's a disease of the heart muscles. And that's about it. And I'll not go into the heart failure part because probably we're running short of time. So, Dr. Thakur, is that where I should wrap up?
Yeah, I mean, I think that's a pretty comprehensive review of things, and I guess a lot to take home, unless people feel,
Yeah.
I mean, need to wrap up and finish at 16:30 sharp.
Yeah.
For 4 minutes. So you want to talk about something in general?
So I had a few questions.
Sure.
I had a few.
Joseph, is Joseph on the call as well? Joseph may have left. So yeah, you could, if you.
So I have a 6 or 7.
Oh, you're on the call, right? So we could go to a kind of all standard view. You can stop sharing if you feel like, unless you want to.
Okay.
I mean, you can send some resources which we can always pass on to all the trainees. So and we can have a few minutes of general interaction before people finish. I mean, they start to leave anyway, of course, because of the time set for the session to finish.
Yeah.
Thank you.
Yeah. Sure. So I'll stop sharing the screen.
Any questions? Any comments at all? Please post in the chat box. Please talk. Speak out. As you feel. We have got 3 minutes. Sometimes can be quite long. I've sent out the feedback survey already, which we will email as well. So don't do it twice. We have had about 90 plus people attending the session. So that's a great number. Of course, the session's been recorded, so we'll have a recorded version and to kind of share with you all edited in terms of the few things which need to be. That is it. So any questions at all? I mean, the first session was ECGs in context of ACS and a few other scenarios, and then have a quick wrap up of AF, some few things like orbit score and stuff like that, few queries around troponins and how much to chase AF in acute settings like sepsis, etc. We had a good interaction